Thank you very much to the organizers and everybody who's here. These are my disclosures, which are not relevant for this. Antithrombotic therapy in CLI can be viewed as a three-pronged approach. First and foremost, with a goal of decreasing overall cardiovascular events, including cardiovascular deaths, stroke, MI. Also, preventing amputation, wound healing, decreasing acute limb ischemia, need for revascularization, and all while bleeding risk is minimized, primarily major bleeding or intracranial hemorrhage, which could offset any benefit. The problem in discussing this topic is that there are very limited data derived from randomized controlled trials, and most of what guides our practice is simply extrapolated from the coronary literature, which is not ideal. And when we look specifically at data derived from PAD trials, most of these PAD trials just lump together all forms of PAD as if it were a homogeneous condition, and CLI is vastly underrepresented. And when CLI patients are included, they tend to have milder forms of CLI, such as Rutherford class 4. And to add complexity to the topic, about 50% of CLI patients at best undergo revascularization, which then brings the issue of how to maintain patency of the artery that has been revascularized. So a fundamental question is, should CLI patients be even considered as a different entity to non-CLI PAD patients in terms of antithrombotic therapy? But there are a few things that really distinguish CLI from non-CLI PAD patients. Number one, they definitely have a higher cardiovascular risk, higher risk of male, higher risk of bleeding based on comorbidities, age, renal disease, et cetera. And they tend to have more severe and diffuse vascular diseases. And as I mentioned, they often undergo revascularization procedures. These are contemporary data on the cardiovascular outcomes of CLI patients. And as you can see, the outcomes, despite everything that we have nowadays, are still horrible. So you can see that a low ABI has a very high event rate. In a Japanese series of 662 patients, one-year mortality 33%. In a Swedish registry, 34% mortality in MACE by 3 years. That despite all of the therapies available nowadays. And limb outcomes are still pretty bad. Again, in contemporary data, 11 to 14% of patients, almost regardless of whether they undergo revascularization, will end up with amputation at 1 year. And as I mentioned, risk of bleeding is significant. So setting all the theory and considerations aside, at the end of the day, these are the options that we have for antithrombotic therapy. We can use single antithrombotic therapy, single antiplatelet therapy, dual antiplatelet therapy, anticoagulation therapy, or combine both antiplatelet with anticoagulation. There is a theoretical reason why we would use dual antiplatelet therapy in CLI, and that relates to their risk of thrombosis, both in terms of MACE and limb outcomes. This is an image showing a platelet monocyte complex. This is a monocyte. This is a platelet adhering to it via P-selectin PSGL1. This is a good marker, well established for thrombotic risk as well as inflammation. And it has been shown that using dual antiplatelet therapy decreases the number of platelet monocyte complexes that are detected in circulating blood. However, when this is tested in a clinical setting, such as was done in the Charisma trial, there's really no significant advantage of using dual antiplatelet therapy. There's a small reduction in ischemic endpoints at the cost of increased risk of bleeding. So the consensus interpretation of Charisma is that these data do not support the routine use of dual antiplatelet therapy in PAD patients and almost by extension in CLI patients. Euclid was a randomized controlled trial. It was a negative trial that compared head-to-head clopidogrel versus ticagrelor. Big failure, but it did include about 640 patients with CLI, generally mild CLI, Rutherford class 4, and while there was no difference between clopidogrel and ticagrelor in terms of the event rates, both limb and cardiovascular event rates, I think that the take-home message of this sub-study of CLI patients in Euclid is that the outcomes, again, in CLI versus non-CLI were pretty bad. CLI patients had high event rates despite anything. So the current AHA/ACC guidelines do not provide any form of strong recommendations for dual antiplatelet therapy in patients with CLI or PAD. So this is a 2B class recommendation. When we look at the role of dual antiplatelet therapy in patients with surgical bypass grafts, we can look at the CASPAR trial, which used the combination of aspirin and clopidogrel. 66% of patients in this trial had CLI, and a fair number of them had CLI Rutherford class 5. But despite this, there was no important difference between using single versus dual antiplatelet therapy. Perhaps one exception was the use of dual antiplatelet therapy in patients with prosthetic graft did lead to slightly improved patency rates. Anticoagulation for CLI, very limited information. Perhaps one of the best data that are out there come from the Dutch bypass oral anticoagulant or aspirin trial. These were patients, more than 2,500 patients, randomized to either vitamin K antagonists or aspirin after infrainguinal bypass. A fair number of them, about 50%, had CLI. And the only thing that was seen is at about 31% reduction in the risk of graft occlusions, especially when autologous vein was used. Based on these data, the current recommendations are that number one, anticoagulation should not be used with a goal of reducing cardiovascular event rates. However, in selected patients, anticoagulation may be used if there is concern about graft occlusion to maintain patency. One of the ongoing trials that I would ask that you keep an eye out for is the Voyager Pd Trial. This is a study that has tested the combination of low-dose rivaroxaban 2.5 BID on top of aspirin against aspirin alone in PAD patients. Enrollment has completed as of this month, it is my understanding. There's a fair number of CLI patients included in this trial, and I think it'll really add to this field whether we can combine safely anticoagulation and antithrombotic therapy. So in summary, there is very little data to guide our antithrombotic management of CLI patients. These patients are at increased risk of any bad outcome that you can think of, as already discussed. Most people use dual antiplatelet therapy for 30 days. Some people extend it to 3 to 6 months. Perhaps dual antiplatelet therapy for prosthetic grafts, and perhaps anticoagulation in very selected patients with autologous vein grafts. Thank you very much.